Hello and welcome. I am Mandel Scher. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for the second of two CMEO podcasts in the series Chronic Cough, a burdensome journey with new therapies on the horizon. This episode is a guide to new and emerging treatment options for chronic cough. This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. This activity is supported by an educational grant from Merck Sharp and Dome Corporation, a subsidiary of Merck and Company Incorporated. Again, I'm Mandel Scher, founder of Scher Allergy Specialist Center for Cough located in Largo, Florida, and a clinical professor of medicine and pediatrics for the University of South Florida Pediatric Allergy Immunology Program at Johns Hopkins All Children's Hospital. I'm pleased to be joined today by Dr. Noor Kazaz. Dr. Kazaz is a clinical pharmacy specialist in pulmonary medicine at Temple University Hospital Lung Center in Philadelphia, Pennsylvania. Welcome, Noor. It is so great to have you joining me, and I really look forward to our discussion.
Thanks, Mandel. It's a real pleasure meeting you, and I'm really excited to discuss this really important topic today.
I'm excited also. Let's jump right in. What we're going to do, just to sort of frame today's program, is start by reviewing our learning objective. After participating in this activity, the learner should have a clear picture of new and emerging therapy promising for the treatment of chronic cough by looking at the most recent efficacy and safety.
Well, thanks, Mandel. Some things that we do know about cough is that it's an extremely common complaint of our patients. So a cough can be acute, which lasts 3 weeks or less, subacute, which is 3 to 8 weeks, and a chronic cough can be a cough that lasts 8 weeks to even years. So cough is prevalent among 10%. However, this is very hard to capture because of the lack of ICD-9, ICD-10 specific codes. So it's not like you can run a report in all of the databases at different institutions to capture this. So likely the number is higher. So chronic cough has a heavy burden. For example, it can affect a patient's quality of life. Sometimes I know there are patients who sometimes are afraid to speak because they know they're going to cough. And it can result in incontinence, and it even can be perceived as an annoyance or an inconvenience to others, such as family and coworkers. This can actually cause anxiety and frustration and depression and fear in social settings. If someone's going to be afraid they're going to cough, they might avoid different gatherings if their cough is so persistent. Cough also utilizes healthcare needs. Because a patient doesn't know the exact cause of the cough, they can go around to many different doctors, from their primary care to pulmonologists, to many different specialties to find out what the cause of the chronic cough is. And a lot of times a chronic cough can be overlooked by different healthcare providers. If there's no known cause, if it's not a cancer or anything, this might be overlooked by some healthcare providers and be just seen as an inconvenience. And most of the treatments lack acceptable tolerability and therapies. So commonly in my practice, when we see patients, we want to find an identifiable cause for their cough. So we want to find anatomic etiology. So a patient can have GERD, cancer, pulmonary fibrosis, or even postnasal drip and pneumonia. A lot of these times when you treat the underlying cause, such as GERD or pneumonia, you can actually treat the cough. So a lot of these patients will go to different testings. The patients who are recommended for GERD, a GERD workup will go to the GI suite, and other patients on workup for pulmonary fibrosis, they will get x-rays and CT scans and pulmonary functions tests to rule out that cause. A lot of the times when you do treat the underlying cause, you can also treat the cough. So the pharmacist, we can educate the patients in the common cause for the cough. We can actually refer them, especially in the community setting. If we see a patient that's constantly complaining of a cough, we actually can tell them, you know what, maybe you should see the doctor and recommend the specific type of physician that a patient can see. Not all patients know that they can see an actual pulmonologist or an allergist to help them rule out their cough. And then we can help them with that and help the patients actually get trust in the healthcare system so that they can seek more help. We can counsel the patients on the different over-the-counter therapies for the cough if it is an acute cough. And then if a cough persists, we can see, have we actually overlooked any anatomic cause for this cough? So for the acute and subacute cough, our best management strategies are just symptomatic. And it's important to know that the last FDA-approved agent was actually in 1958. So some of these things to treat acute coughs are cough drops. Cough drops can be cumbersome in that you have to constantly take it throughout the day. Antihistamines can cause drowsiness. Benzonatate is just purely symptomatic. And a lot of our patients in practice, this doesn't even work for them. Then there's hydrocodone and codeine, and there's always problems with abuse with these agents. And then you can treat the patients with steroids. And we all know that there are many side effects of different steroid bursts. Patients can become steroid dependent. They can get side effects from the steroids, such as weight gain and mood changes. And overall, giving patients chronic steroids or multiple steroid bursts for a cough is not a good idea, especially because we're not finding out the underlying cause. So since there are no currently FDA-approved agents specifically for cause, we have to look beyond that. So, Dr. Mandel, when you see a cough that lasts longer than 8 weeks and doesn't go away, what do you recommend? And can you give us some insights in some of the new concepts and medications that are being studied for these types of patients?
Noor, thank you for that excellent review of the state of the art of where we are with patients with chronic cough. And we find that many of them go on this long, burdensome journey and are still coughing. And there's two definitions that have been developed operationally for these groups of patients. One is refractory chronic cough. This is a cough that persists despite guideline-based treatment for underlying conditions such as GERD, asthma, and upper airway involvement, be it rhinosinusitis. And then there's those coughers who are on this journey that have no identifiable cause, and they're still coughing. And we call this unexplained cough, a cough that persists longer than 8 weeks and remains unexplained after that investigation. So to understand this, to understand what's going on with these patients, I think we have to start to understand what cough is all about and get back to basics. First, we have this protective cough reflex that's needed for our survival. This protects us against aspiration of stomach acid, of foreign bodies. It also will help clear mucus and inflammation from lungs. It's a very persistent reflex. It is hard to suppress. It occurs in the conscious and unconscious state, so it will occur even under anesthesia or with sleep. The second cough process, which is what we're really addressing today in these patients, is the irritative cough reflex, or what I like to say is a response. It's that tickle in the back of your throat, that urge to cough, that will lead to the cough. It is set off by chemical irritants, lung inflammation. Actually, the common cold is one of the most potent triggers for this irritative cough reflex, and occurs while we're awake, but tends to go away during sleep or being anesthetized, which will be a clinical sign to help differentiate a pathologic or protective cough from this irritative cough. Now, to understand the pathophysiology of this cough, there's this slide. For this somewhat complex, not fully understood pathway, we see that there's receptors sitting in the throat, the chest, the lungs, the esophagus, the upper airway, and these pathways of various receptors will then travel up the vagus nerve to the midbrain. The protective cough just stops there and responds. But the irritative cough also will go up to the upper cortex. And we see that the irritative cough will have an effect of upper brain function. We see that cough is voluntary. And we see we have inhibitory factors in the interpretation of this urge to cough and how we respond. Now, there's a lot of candidate pathways and receptors, and several of them are listed on this slide. But one that is turning out to be possibly very important, particularly when it comes to therapy, is the P2x3 pathway. This is a pathway that's seen in the lungs, the pharynx, and will be triggered off by ATP. ATP will be the result of infection and inflammation, and it will activate the P2x3 pathways that responds primarily in the midbrain, but doesn't go up to the upper brain. And we'll see that the therapies for this, therefore, don't have a lot of systemic side effects. Now, on this slide, there's two little round areas. The P2x3 homotrimers, or three of these receptors, mediate cough. But the heterotrimer that has a P2x2 may mediate cough, but clearly mediates taste effect. And we'll see as we talk about therapy how this comes into play. So hyperexcitability of sensory pathway, which we believe is what's going on in these coughers who cough for 8 weeks to decades as a mechanism for why they cough, is not really a new concept. So Nur, could you kind of review with us how this pathway may also affect other different organs?
So what I'm hearing you say is, I guess the overstimulation of the sensory overstimulation is kind of what's leading these patients to cough. And now that we can accept a sensory pathway, we can probably find treatment options. And this was commonly found in different conditions when we didn't know how to treat, like fibromyalgia. We knew patients were experiencing pain. We knew that they didn't have good medical options and they were tired. And now there are better treatment options for these patients because now we know where we are targeting. So I think when you find the target, you can find better treatment options. The same thing goes for neuropathic pain. Once we find out that we actually have to target different nerves, we can actually treat these conditions. So what I'm hearing you say is, with chronic cough, once we find a receptor and we find a target, we can actually treat cough as not a symptom, but as an actual condition. So is that what you're seeing with your patients?
Well, so what we have is this concept of these nociceptive pathways being hypersensitized. And we see it in multiple different organic diseases, as Nura's described. So we have a clinical presentation for these patients, which is, I think, important for you as pharmacists and we as healthcare providers to be able to identify these individuals. So in this case, the cough is not a symptom, but is actually the condition. And they present as a tickle in the back of their throat or upper chest. They'll complain of postnasal drip, but if you ask them about mucus production, many of them do not make mucus. It's just the sensitivity of mucus. We'll see triggers will occur from things that normally don't cause cough, such as talking or smells or air conditioning, and they'll be hypersensitive to other things that typically would trigger off cough, particularly viruses or cigarette smoke or high irritants. And many of them don't cough during sleep versus a pathologic cough that would tend to wake you up at night. So we see that we have a patient profile that can identify this type of patient. So let's go back to our definition of what we said about these chronic cough. We have refractory chronic cough, where we have these associated conditions that are treated, but they're still coughing. And what we see is that there's a whole bunch of patients with acid reflux, with asthma, with postnasal drip rhinitis who never cough. What I believe that differentiates our patients is that they have that additional pathophysiologic disruption, which is they're wired to cough. And that's where these other conditions are actually, rather than a true cause, is a trigger for that type of patient. On the other hand, the patients who have cough hypersensitivity syndrome may not have any of these conditions, and that's why we call them unexplained chronic cough. So before we move into the exciting new data on how we can treat cough hypersensitivity with these novel cough drugs, Nur, why don't you review some of the neuromodulators, as we call them, or cough suppressives that are available that we're using in current practice?
Okay, so some of the therapies that we're using are some different neuromodulators. It's important to note that these are actually, again, not targeting the specific cough receptor, and that their overall effects probably are more systemic than just targeting the cough. And a lot of these agents, actually all of these agents, are all used actually off-label. The gabapentin dose is pretty big. It's 1,800 milligrams. And if you've ever used gabapentin for your patients, a lot of the complaints will be fatigue and tiredness. So a lot of the patients' coughs can go away, but they'll primarily complain to you about, well, I'm barely able to focus. I'm very tired, because they're taking such a big dose of gabapentin. We're basically blocking a lot of different receptors just to block out the cough. Another agent that's used is Pregablin. Now, Pregablin is a controlled medication, so depending on the providers that you go to, they may be apprehensive to write this for long-term treatment of cough. Although this did improve the cough severity, but it did not improve the actual cough frequency. And some of the side effects with these medications are dizziness and some cognitive changes and even blurred visions with these patients. The last agent that's another neuromodulator is morphine. And this could be difficult to find a provider who's going to give a patient morphine chronically for a cough. The doses range from 5 to 10 milligrams twice a day, but it is effective. But once again, providers could be apprehensive to treat patients with cough with an opioid. It can cause dependence, and there are many long-term effects of using opioids for these patient populations. Okay, so now that we've discussed the different neuromodulators and the potential side effects and how their targets are pretty much systemic, can you tell us about the CNS and the sensory targets specific to cough, and what's in the pipeline now for these patients and what it means for their chronic cough treatment?
Nur, what's exciting is that we're now coming to a point in the journey of finding an acceptable, effective cough drug with acceptable side effects that has been the holy grail for the pharmaceutical industry going back to 1958, as you mentioned, which was the last drugs approved for cough, which was dextromethorphan and benzonatate. And it looks like we may be getting close to the finish line. And that's the group of medications that are P2x3 antagonists. As I mentioned, the pathway that appears to be playing a significant role in many patients with particularly chronic cough. And this slide reviews the 4 candidates that are in various stages of development, of which gefapixant has now finished 2 phase 3 studies, which we'll review. And the data is now sitting in front of the FDA for approval. The other 3, P2x3 antagonists, that are in generally phase 2A and now 2B studies. And each of them have a different selectivity for the P2x3 receptor versus that heterotrimer that involves taste. An addition category that's now has completed a phase 2B study is an Nk1 Receptor Antagonist, another pathway that does appear to be possibly an effective drug, and that's orvipatant. Now, so let's move on and now talk about gefapixant. And this next slide will review what was the data that was used from the phase 2B studies to pick a dosage for the phase 3 studies, which we're going to review. And we see that the blue line going down from left to right is the efficacy, the drop in cough counts, which is what has been used as the primary readout or outcome in these studies. The development of the cough monitor, which has been used, has greatly helped advance studying cough because we have objective criteria for outcome rather than just subjective feelings of, do I feel better? On the other hand, this drug, which we say doesn't really cross the upper brain very much, doesn't, as we'll talk about, doesn't have significant systemic side effects, but it does affect taste from a central nervous standpoint. And we see that red line going from left up to right is showing the taste disturbances. And we find that they pick two lines, 15 milligrams and 45 milligrams, to be assessed in the two phase 3 trials in their twice-day dosage of these drugs, which, as we will review on the next slide. On this slide, we see the results of the two large phase 3 studies studying gefapixant. COUGH-1, which looked at efficacy at 12 weeks, and COUGH-2, which looked at 24 weeks. Altogether, about 2,000 chronic coughers with greater than 8 weeks of cough, having cough at least for a year, who did not have any other identifiable causes, were studied for efficacy and side effects of this product, gefapixant. And we see that if we look at the cough count outcomes, that between 14 to 18% improvement was seen that was clinically significant with a p-value less than 0.05 for significant drop in 24-hour cough counts. Now, while that may seem small, it needs to be understood that there was a very large placebo effect in this study and in most of the current cough studies for reasons that we don't fully understand. But we see that at least 70% of the coughers in these studies had more than a greater than 30% reduction in cough. On the other hand, let's look at side effects. What's really important to realize is that significant systemic side effects were not observed, in contrast to a lot of our present cough drugs, which do have a lot of upper cortical involvement and side effects that are not desirable. The one side effect that was seen fairly commonly was altered taste. When it comes to altered taste, we see that in these two studies, 58% and 69% of the patients in COUGH-1 and COUGH-2 respectively had taste effects. And withdrawal from the study between 15 and 20% resulted primarily due to taste. So we see that we have a potential effective cough drug with not serious or significant systemic side effects, albeit they have taste effect, that is may soon be available to us with other candidate P2x3 receptor antagonists in the pipeline. So we've talked about some new concept in chronic cough and taken a look at some promising agents to use in the future. Nur, why don't you tie this all together for us and for the pharmacists? What do you see as the intervention points and contributions that pharmacists can have to enhance patient care?
Well, I believe that pharmacists are some of the most accessible healthcare professionals, and I believe that we can always come back and help patients optimize their therapy. So we can counsel the patients, and we can actually help facilitate their process in seeking different opinions from different healthcare providers. We can counsel the patients throughout the process. We can provide them over-the-counter options when it's feasible. We can also introduce the patients to different research trials. I know that some of the things that we do in our clinic is we discuss research to patients and we tell them why it's so important. And we tell them how these drugs could potentially work and how their contribution to the healthcare system can really help us find out how these medications are really going to help the patients and future advancements. Another thing that we can do is give the patients hope that it just doesn't stop here, that we know that you're struggling with your chronic cough and that this is something that is being researched. And we can talk to them about the new mechanisms, explain to the patient, well, you know how your previous drugs kind of gave you all these different side effects. Well, they're looking at something that's really going to target and pinpoint this cough. And I think that's something exciting, and it's something promising for the patient population. I know that some of the drugs that you discussed in the trials, we've actually introduced them to our patients, and we've told the patients that some of them are the taste disturbances. And a lot of patients say they wouldn't even care if they have taste disturbances as long as they can actually get rid of their cough. Okay. I also think it's important for us as pharmacists to collaborate with providers, collaborate with different doctors, nurses, different healthcare organizations, and talk about cough hypersensitivity as it is a chronic cough, and that it can occur with a disease state such as GERD or alone. And we also want to bring up the notion to different providers that if a patient's cough persists greater than 8 weeks, that potentially it could be a hypersensitivity with a chronic cough, that there could be a specific pathway, which is the type C fiber pathway leading to the urge to cough or that tickle in the throat that the patients feel. We want to talk to different providers and patients about the new target agents in trials and the promising hope in the effective treatments for chronic cough. Now, Mandel, it's been a pleasure to join you today for this discussion. Can you help us wrap this up?
Nora, this has been a terrific discussion. I'm so glad that you reviewed the SMART goals, which are smart, measurable, attainable, relevant, and timely. I want to also remind our audience, and this is the second podcast of the series of 2, and I hope that you will join in to listen to the other podcast titled The Pharmacist's Role in Improving Early Diagnosis for Patients with Chronic Cough. Please remember to collect credit for this activity by clicking on the button that states Apply for Credit. You will need to provide your NABP number so that we can report your credit. On behalf of Nur and me, thank you again for joining us today. I do want to let our audience know that we are developing additional resources on how pharmacists can recognize and refer patients to the appropriate provider. Please visit the URL that's going to be on this slide for access to these resources that will be available in the coming weeks.